I'm super excited today to bring to you an interview with one of my favorite OB-GYNs, Dr. Tara Scott. Dr. Scott and I met virtually through an A4M conference, and I wanted to get her on the show because I love the way that she brings the content of hormones to her audience. I think it's really going to speak well to this audience. So the interview is going to go through mostly estrogen and progesterone. On today's video, we're going to save androgen and testosterone for another day because we just really got into the space of estrogen especially. And so I love the way that she's seeing patients. If you're not familiar with Dr. Scott, she is a practicing OB-GYN. She no longer does the surgical side of GYN and is now in the space of education. She has a company called the Hormone Guru, and you can look her up online, Dr. Tara Scott or the Hormone Guru, and you'll see all this content that she's bringing forward to women, helping them to understand that they have the potential to optimize and improve hormones and balance hormones in a way that is outside of the box of the traditional medical model. So stick around if you want to hear me chat with Dr. Tara Scott on estrogen and progesterone. I hope you enjoy. All right, Dr. Tara Scott, thank you so much for joining me on the Dr. Doug Show. I have so many topics that I want to get into, but first I just want to say thank you for spending your time with us.
Yeah, and thanks for putting all the time into this. I know it's a great way to get information out to people.
Yeah, I think we're on the same page there. So I would love to just get a little bit into your background. I'm going to let you do it. In our introduction, I talked a little bit about where you come from, but give us a little bit of your story about, how you got to where you are, why you're doing the type of practice that you're doing now. Because I love what you're doing, and I love the message that you're getting out to people.
Yeah, so I'm a very traditionally trained doctor, OB-GYN, and did delivering babies and surgery for many years. And right about the time when the WHI came out, which is the Women's Health Initiative in 2002, there was really kind of a vacuum of information. And I personally had been an infertility patient, had hormone issues, couldn't get pregnant unless I took those drugs. And then after you're kind of pregnant and done being pregnant, there's nothing for you if you have any hormone issues until you hit menopause, and even just for the people in perimenopause. So I started becoming, educated in the hormone world, became, a menopause practitioner from the Menopause Society. But really the deep dive was when I found A4M and did much more studying on integrative and functional medicine. So the last 20 years, that's been kind of my wheelhouse. And I see women of all ages with hormone disorders of all ages.
Yeah, that's awesome. And I would love for you to speak a little bit too about sort of your passions around like the Hormone Guru. That's what I see you as on social media, versus clinical practice. How are you bridging both of those? And do you still see patients?
I still see patients in an Akron, Ohio office of Forum Health, and I have a great team of nurse practitioners that also see patients there. I'm doing a lot of educating, though, through my Hormone Guru company, and I have an online kind of an educational online course that people can do if they have a hard time working with practitioners. There's still not a lot of people who are in this niche and industry, and women are really starving for information and guidance. And although we can put so much out there educationally, a lot of times you can't give personalized advice. So they're still searching for some help. That's why I spend, and I'm sure it's the same reason you do too, the time on social media, YouTube, TikTok, Instagram, all that stuff, trying to put things out there to hope that it's going to help someone. And maybe they can take that to their provider, or maybe they can find a provider somewhere, or maybe they can take some of the information and some of the standardized suggestions to make some changes in their life to help things too.
Yeah. Well, I think it's so important too for people to understand that there are different opinions on the topics of hormones. And so I've looked at a lot of your content. I know we're on the same page on most things. So it's challenging when I see other influencers in the hormone space who are just kind of propagating some of the outdated information that I'm sure you were taught, that I was taught, even when I went through, the A4M sort of anti-aging stuff. Some of these old habits die hard. And so getting updated information out there, the newest information out there, so that we can really help women to get the information that they need to be empowered to make the changes they want to change. So it's awesome. Yeah.
So Wild West out there is no standard in hormone replacement. Really, that's part of the problem. There's no algorithm. There's no real protocols. I mean, there's traditional OB-GYN, and even your OB-GYN might not be the person who is knowledgeable about menopause. So
Right, for sure.
yeah,
Well,
but I think, as with teaching, you have to be able to give evidence behind what you say. You can't just go out there and make a claim or do anything if you don't have a study to back it up or some physiological science to back it up.
Right. Well, and that's what I love about your content too, is because you're like, this is what this says, and this is how I interpret this clinically, because you are both a researcher, you're a speaker, and you're also a provider. So you're having to do it in all three of those spheres, which I think is really important. So I'd love to chat today about really, I think we should hit on sort of the three primary sex hormones. I want to start with estradiol because our population, the listeners of this channel and the podcast, we talk a lot about estradiol. And I would love to get from your perspective with both your OB-GYN background, but then also, the A4M functional medicine background, how you now view estrogen when it comes to, we're going to talk about the benefits and the risks. But let's just start with the thing that people ask me about most, and I'm sure it's probably what they ask you about most. So let's talk about estrogen and breast cancer. Is that all right?
Sure.
Great. Yeah. Because some people just don't want to talk about it. And we have to talk about it. And this comes up for me because I see patients that have osteoporosis. They would wonderful if they could be on estrogen. And then they have, some of these red flags. And they say, well, but I have a family history. I have a personal history. I have a fear. I think about breast cancer all the time. And so from your perspective, when we start using estradiol, and we can talk about different populations, but we're using estradiol mostly in a postmenopausal population to make it clear. What are your thoughts on estrogen, the risk of breast cancer, causative, associative? How do you educate people on this?
Well, so, the fear of breast cancer stemmed from the WHI. And so what the Menopause Society finally came out and said is that it's the type of hormone. So is it estradiol? Is it ethinyl estradiol? Is it conjugated equine estrogens? That affects it. The route of administration, the dose and the duration, that all encompasses what you're giving and what the risk is. And then there's this issue with the progestin versus progesterone and the difference in risk between that. So you can't make a blanket statement. Although if you polled 10 gynecologists, 9 of them would tell you it causes cancer, right? Yeah. Still to this day. And that's the antiquated teaching and the lack of teaching. And so, the latest menopause position statement of 2022 says the risk for breast cancer with hormone therapy in all types is 1 out of 1,000. Now, if you choose to use Premarin and Provera, it's 3 out of 1,000. And the thing about breast cancer is, if you talk about osteoporosis, the death rate 2 years after a hip fracture is much higher than 10 years after breast cancer diagnosis, but everybody fears cancer. Correct. And so there's still this stigma around not taking hormones, or I can't take hormones. So I saw a patient yesterday that had BRCA1. She had a prophylactic mastectomy and oophorectomy at 40. And there's tons of data that if you take out ovaries before 45, there's a markedly increased risk of heart disease, which is the number one killer in women, 2 stroke, 3 lung cancer, 4 breast cancer. If you add up the deaths from 2, 3, and 4, you still don't equal the deaths from heart disease, right? That's a bigger problem. Right. And so nobody gave her hormones, and she's for 5 years had no hormones. And so her OB-GYNs gave her citalopram, an antidepressant, and gave her vaginal hormones. And so guess what? She has osteopenia. Yeah. And so with BRCA patients after a prophylactic mastectomy, the guidelines from NAMS is to give hormone therapy from the American College of OB-GYN, give those patients hormone therapy at least till the age of natural menopause, which is considered 52. So the guidelines would have said she should have gotten it. Yeah. So the thing about breast cancer, it's going to be stratified. Risk is going to be do you personally have breast cancer? Do you have a family history or a genetic predisposition? Or are you just a general person who is concerned? So we usually go through the risks of that. And when we look at studies, one study observational, but it was studied in 2008. There were 80,000 people. They had a control group that took no hormones. And the people that took transdermal estradiol and micronized progesterone had no increased risk of breast cancer. They were 40 to 64, and that study lasted 8 years. But the people who took estrogen only had an increased risk of breast cancer, and the people who took estrogen plus a progestin, a synthetic progestin, similar to what we would see in a birth control pill, they also had an increased risk of breast cancer. So I think I would talk to my patients about, here's what we're going to give you. And there's also articles too. I know we touched on this about monitoring, and there's no standard. The guidelines say don't check hormone levels. Because if you look at the guidelines from the Endocrine Society for men, it's check levels, give hormones, monitor levels. Even transgender therapy, check levels, give hormones, monitor. But for women, don't monitor. Hormone levels don't mean anything. They're too erratic, which just give hormones. So there's actually data published that serum levels can predict breast cancer risk. So I do think it's relevant. And I think the patient who has a family history of breast cancer could possibly take hormone therapy if they're properly monitored and assessed. The random patient that has no history of breast cancer, again, 1 in 1,000 is what we quote you, the risk is. Now, the breast cancer patient is the one that's tricky. Depends on
Mhm.
how old she is, how long it's been since her cancer, what type of cancer she had, what stage she had, what the receptors were. But I have breast cancer patients. I had a patient who had breast cancer at 38. She had she didn't have recurrence. She had breast cancer, and then she had an osteoporosis related fracture at 41.
Yeah.
And so she came to me when she was 50, almost 50, wanting hormone therapy. And she's 10 years past her cancer. So we gave her estrogen, we gave her progesterone. It's game changing for her, you know?
Absolutely.
So
Yeah, and I do the same, but it's been really hard to get over that hump of saying like, oh well, you had breast cancer, like I can't do that. But the literature is pretty good. I wish we had better literature, but I still think it's pretty good. So then where do you draw the line from a family history perspective? Because we hear this all the time, right? So my aunt had breast cancer. I have one family member. What's the stratification from your perspective that we need to pay attention to?
So that to me is not a contraindication to take hormone therapy. And again, I'm not going to make a general, everyone can take it that has one relative. We're talking about an N of one, right? So in my patients, I'm evaluating baseline levels, I'm monitoring levels, and I'm also checking something called estrogen metabolism.
Mhm.
So I think for me, and I have a lot of breast cancer patients that I see either after diagnosis or after, especially premenopausal, that want to lower the risk of recurrence. And I feel that one of the reasons people get breast cancer is because they don't clear estrogen. So think
Mhm.
about estrogen as what you're charging on your credit card and progesterone what you're paying off. So if you have a discrepancy and then you are accumulating a finance fee on your credit card, even if you cut up that credit card and never use it, you're still going to be paying on that. So women don't always clear estrogen. So that's more stimulatory. And if you don't have estrogen causes growth and progesterone causes cell death. So when you don't have that balance, you get growth.
Right.
And there's actually a study, old study in 1995 by Chang, where they actually put progesterone gel on the breast and they put estrogen gel on the breast, and then they did biopsies in the follicular phase. So there's no body's progesterone. And what they found is that in the cell, progesterone did the same thing it did in the uterus, which is cause apoptosis and just prevent proliferation.
Yeah.
So it is protective on the breast. And so there's a lot of factors that goes into if you have a family history, or if you've had a breast biopsy or dense breast, or if you have a genetic predisposition. Now, the genetic predispositions are mutations of tumor suppressor genes. So there's also mutations of detoxification genes, right? That can contribute to an increased predisposition of breast cancer, uterine cancer, any hormonally sensitive cancer. So we're checking all that out in our patients.
Yeah. And that's so this is I think why it's so important to have somebody who knows what they're doing, somebody who for them hormone therapy isn't something that they don't like and that they don't want to spend time on, because you do have to go down all of these rabbit holes from a patient history perspective. It takes a lot of time. So I'm glad to hear that you're doing it. You brought up screening, and I did want to touch on that briefly because this is another area where like I just scratch my head at the screening recommendations. My wife is, I'm not going to say how old she is, but she's in the era to get screened, right? And what she's told to do and what I hear from other patients, it just blows my mind what we're asking women to do for screening for breast cancer. So can you walk me through how you are recommending patients follow this? Because you're dealing with the quote unquote dangerous hormone. So how are we watching for occurrence?
So that is so hard to straddle between traditional, right? And so remember that with screening, they're worried about population health. So with a mammogram, they have done demographic studies to prevent the population. So they're looking at how likely is this modality to prevent the population from getting breast cancer. They're not looking at an N of 1. And so the actual modality of mammogram is not a very good screening. And so they're really aimed at early detection. So I want prevention, right? So because I don't actually practice GYN, I'm a consultant. They're required to have their own GYN and, PCP.
Mhm.
So I'm not actually even ordering mammograms now. And so that is the ACOG recommendation, is to get a mammogram. A lot of my patients will get a thermogram. Now, there's no population screening studies on thermograms, but the science is interesting. And I think you're going to see rapidly dividing cells prior to you're seeing calcifications. By the time you see a calcification on mammogram, likely that's could have already been a cancer there.
Yeah.
So women are seeking out their own screening, more of the thermograms and more of this, let me be preventative of monitoring my hormones. Let me make sure, my estrogen metabolism is good. And let me do all these other things to decrease my risk of cancer. Don't smoke, right? And there's other studies about alcohol, red meat, all kinds of things that they can do to decrease their risk that they're trying to do if they feel that they're high risk. But as far as screening, gosh, that's a tough one to do because we don't have great screening for breast cancer.
Yeah, it's challenging, right? Because once we start prescribing, people are asking us, and I do the same, like you have to have your own primary care GYN. We're not ordering mammograms, but I want to make sure that you're getting whatever it is that you and your team are comfortable doing. But I hear such discrepancy as to what people are recommended, what they're doing. Let's do a mammogram every 6 months with contrast and an ultrasound and an MRI. And I'm like, oh my God, like that's a lot of stuff. Like it just seems like it's too much. But at the same time, you have to do something. But where do you draw the line?
I mean, I think the mammograms are really poor screening. They're very uncomfortable. And if you have large breasts, there's a lot of shadowing. And the issue is that you get these abnormal findings and you go back. The 3D digital mammograms seem to be doing a little bit better job. And the MRI, which is no radiation, the MRI is going to be a little bit better at screening. And so, but you can't qualify for that unless you have, XYZ high risk.
Right.
So, and then again, most masses are found on self-exam. So we're obviously advocating for the patients to do their self-exams every month and try to keep tabs on it with that. But it's a black hole. You're right.
It is a black hole. And I worry too, with the frequency of recommendation, I hear them saying, mammogram every 6 months with contrast. I don't want anybody to get IV contrast every 6 months. That seems like a bad idea.
I luckily have not heard many of my patients with that recommendation. So,
just my personal example, my wife was just at the imaging center this week. And she said, I don't want, because I told her, I was like, I don't think you should use contrast. And this is why you don't treat your family. But so she goes in and they're like, well, you need contrast. And she's like, well, I don't want to do that. She had to explain it 10 different times. And it delayed her care by probably 4 hours because they were so like, why don't you want contrast? And so it's challenging for women to be able to stand up for what they think is right. And I think they do get browbeaten and like, just get your mammogram, just do it. And it's frustrating. And I don't have the answer yet. I'm working on it.
Yeah. Do you know Dr. Jen Simmons? She's a breast surgeon who's now integrative. She is check her out. She just launched a book and she has a new imaging modality. And I cannot remember what the imaging is, but check out her stuff. There is a new imaging thing that she just launched, Q something. And I trust her. She used to be a breast surgeon and now she's focused on same thing. Prevention, integrative.
I will mark my words. I will find her. Have her. She's my next interview. No.
Yes.
But that sounds amazing because I hear it over and over again. And I just can't believe what we're asking women to do from a screening perspective, because I feel like we're doing more damage than good, both physically and psychologically. Okay. We beat that one to death. Let's move on to the second most common thing that people ask me about, which is cardiovascular risk. So I'll just give you this is the question that I hear all the time. Our patient population is generally going to be 10 years after menopause. So we are seeing a lot of patients who are at, the 60 to 64 range because they are in the generation that got, let's just call it what it is. They got screwed by the WHI. And their doctors were afraid to prescribe, so they never had the conversation. Now they have osteoporosis. So they're coming in, they have osteoporosis. They're usually 10 to 20 years out from menopause. and they've been told that they can't start estrogen because of an increased risk of cardiovascular disease. This one drives me bonkers because I think there's so many ways around it, but how do you tackle that?
So I think from your perspective, you're trying to help osteoporosis, right? If someone just comes into me and says, "Oh, can estrogen help my skin now? I'm 76," I'm not really hard pressed to start estrogen on them, depending on why. And I know we're going to talk about brain health, but think about a lot of those studies. First of all, they were on oral estrogen, and I'd have to pull the studies. Were they estradiol? Was it conjugated equine estrogen? Was it Premarin? And so it's a different beast. And some of the later age, say precipitated plaque, when you start it later. Now, again, think about what traditional health was then versus now. Think about we have coronary calcium score, we have carotid intimal screening. So I think in a patient that you're seeing that you're doing all this integrative cardiovascular advanced lipid testing, and you have a non-smoker, someone who's fit, someone who is active, I wouldn't have a problem giving them estrogen. You still have to tell them, you know what, there was this study long ago that showed an increased risk of stroke and cardiovascular, but I would almost bet on the fact it was oral. First of all, I don't use oral estrogen.
Right.
And second of all, I'm betting it was also progestin, because if you're looking at those studies, so how can you extrapolate that? So I think, you got to weigh here is your risk. And I would still, probably document and say, this is outside of what we would normally say. I want you to report to me if you have any, symptoms of XYZ. Be on the lookout for that. If you have leg swelling, don't think about, don't blow it off, that kind of thing. But I think, you're depriving, this is something that could be a good intervention for somebody.
Absolutely.
And I think based on an antiquated study. So I think you take your N of 1 and you assess what is this person's cardiovascular risk based on this. And if they are a good compliant patient, then I would go for it.
Yeah. And that's what we do is we walk them down their own risk pathway. So similar to kind of what you just said with breast cancer, we walk them down a very complex, probably too complex cardiovascular risk pathway, looking at family history, personal history, what do your lipids look like, what are your other risk factors, and then get imaging. If you can prove that they have minimal disease, why would I not allow them to do that, even if they're 20 years out? Now, when you start getting over 20 years out and you're in your 70s, it's been a long time. So I think there is probably a threshold. We have started some patients in their 70s, but their arteries were like cleaner than mine, just clean as a whistle. I was like, I can't. They have a CCTA of 0. I mean, with clearly of 0. I'm like, I've never seen that before.
Mine's 0.
Mine's not. My CAC is 0, but my CCTA is not. And so, I have some plaque and so I'm doing something about that. But these women in their 70s that had 0 plaque, I just can't imagine not starting them on it when they have severe osteoporosis. Heart disease is not likely going to be the thing that kills them.
I totally agree. And I think, medicine has become so compartmentalized again. And I have found that a lot of people don't want to do the deep thinking, right? It's just, this is the protocol. And that's how it is in cancer. And I'm sure that's how it is. Same thing with heart disease. So I think I agree with that.
Well, it's like this, the subspecialists are worried about their thing. And this is why, because we have this conversation around cancer and oncology all the time. You ask your oncologist about it and they're going to say, well, no, it increases your risk of cancer. You can't do that. But take the whole picture into play and you say, well, actually, it increases your risk by maybe this small amount, but look at all these other reasons that are going to outweigh that. But for your oncologist, they're like, no, it increases your risk of cancer. And that's their job. So we do have to keep that into perspective when we're trying to do this. But you and I are in this position where we're trying to put all of the pieces together for people. And it can be a really challenging conversation. Well, let's take a leap from there and move from the cardiovascular risk into the age question. They're very, very related. We just broke down a couple of different age groups. So is there a point at which you won't prescribe for anything other than cardiovascular risk, like we just mentioned? Do you have a hard cutoff, or are you open to that N of 1 conversation when it comes to age?
Yeah, I mean, I'm going to personalize that decision. But what I have found in my patients who are older is that it's generally not an estrogen problem. It's a lot of time DHEA, it's cortisol, maybe even progesterone, maybe testosterone. And I know there's kind of a sort of a recommendation, don't give testosterone if they're not well estrogenized, but they're usually much more deficient in androgens, honestly. And so depending on what we're trying to do now, we don't have the studies on DHEA and bone health that we do on estrogen and bone health, but supposedly there's a thought that it is pro bone.
There's some. Yeah, there's some.
Yeah. I mean, so I think that would be my focus with some people at that point. But I would not be opposed to the patient that, is interested in estrogen. And, most of my patients were starting them on FDA approved estradiol patches, but you have the option of giving bias at a much lower dose if you want, or
Mhm.
some kind of compounded estradiol if you don't want to use bias. You can personalize a lower dose. I know when you're talking about you want to get certain levels for bone health, that might not
Don't
be
use the word
initially.
low dose around me. I mean,
But
we
so it
don't drive
depends on
everybody
you.
out of the gate, right? We don't put everybody on big doses, but we do want to go up when we can. Yeah. So I mean, and I look at it the same way, and like those same 70 plus women that we're talking about with cardiovascular risk. I mean, there isn't another reason that I wouldn't put them on it when we have a clear reason. And I agree that from a bone health perspective, estrogen is probably the most well studied of the three.
Yeah.
But we see, and I want to talk about androgens later, but we do see just globally in this population, and I think it's not unique to this population, but it is rampant in the population of sarcopenia and osteoporosis, androgen deficiency. I mean, they're not making any DHEA, none. So we're measuring DHA in everybody, testosterone, free testosterone, and they have none. So it's a tool. It's definitely a tool. I want to save that for later because I want to finish estrogen. There's been a lot of discussion. You mentioned it earlier, looking at breakdown products of estrogen. This is controversial in the field of OB-GYN, and one of the reasons why your content caught my eye, because you've clearly looked outside of your box of GYN training and hormone training within that subspecialty. Estrogen breakdown, when we're trained through A4M, when you're trained in the functional medicine world of estrogen breakdown matters. Can you give us a little background on why it matters and then how you're using this in your practice?
Yeah, so I don't know how it wouldn't matter. Honestly, it's like think about when you're talking about antibiotics and people with kidney failure, how you worry about clearance and how your dosing is adjusted. It's the same thing, only our estrogen detoxification happens in the liver than in the gut. And if you're not pooping it out, right? And so it does there's a lot of studies on it, and I've seen some of my traditional colleagues post that, oh, the gut, you don't recirculate estrogen. And then I'm like, well, I wonder if that's ever been studied. Go to PubMed, tons of studies on beta glucuronidase and estrogen levels and gut and breast cancer and everything. So it's all there. It's foreign to us and we are not taught about it. But it makes tons of sense because I would see patients in my traditional GYN days that were, whatever age with no ovaries and no symptoms. I'm like, how could they not have estrogen and not have any symptoms? And then I even would see patients in their late 60s have tons of estrogen, serum, not just
Mhm.
saliva, serum, and urine, but even serum levels with no ovaries. Like, how is that? So it's so fascinating to me. And then this whole thing about aromatization is a huge thing that's not looked at, even just estradiol to estrone, testosterone to estrone in men and women. I mean, it's people missing the boat on that,
Right.
what you do, and especially with women and testosterone. So I think it's very, very important. And so if you look at the estrogen metabolism, there's not a lot of published studies about it. I mean, I looked mostly under the guise of breast cancer. Somewhere around 2015, the assays changed. And so they weren't very accurate prior to that. So after 2015 is when one of the labs came out, a couple labs came out with dried urine. So it's a little bit easier than doing the 24-hour urines that you would have to do a representative thing, carrying the jug around.
Right.
And I was doing estrogen metabolite testing before that. But after 2015, it became much more convenient. And one of the labs that is running that test is really doing a lot of research and publishing papers and doing a lot of trying to get CLIA certified, clinically validated, right?
Yeah.
I think the jury is out as to whether estrogen metabolites can be used to monitor dosing.
Yeah.
And Mark Newman and I have this
We don't.
discussion all the time.
Yeah.
But
We don't use it for that.
I
But
think it's difficult to do that. But I
yeah.
will tell you, it's a great test to look at. You got to see how someone is clearing estrogen. And I think that is the problem again with the cancer and all the other things in excess. So I do think everyone at some point on estrogen should have it done. I'm not saying you got to do it every year. I'm just saying you got to do it
At
and
one
see
point. Yeah.
how does it work? Is it good? Is it bad? Do I have any concerns?
Yeah, that's a really great perspective. And we were using it a lot early on. And I think this is like kind of an early provider anxiety, right? You're like, oh my gosh, what's happening with the estrogen? And then we found that it wasn't really changing how we were treating people. We're still doing blood. So we weren't using it for dosing. But I see the same things too in the OB-GYN influencers who are very traditional, just hammering like, you shouldn't use this test. There's no evidence to support it. This is all a scam. And and I agree with you. We were talking before we started recording about, what what do you do when you see people that you really disagree with, and try to be polite, try to be professional. But I really want to just like download all of that data and just dump it into a comment and say, look, here's a PubMed search with 500 studies. So there is data. Now, do we have massive randomized control trials on the? Of course not. And we're never going to. But like you said, and I don't mind mentioning companies. I'm assuming you're referring to Dutch. Yeah. So, Dutch is the company that we use. It's what our team is trained on. And, they do have reasonable data. The question I have is, where does it fit in? I would love to see it on everyone too. Then it just becomes a question of resources and, how often do you do it? And I know that's another challenge. That's a whole nother webinar.
The testing question is a whole other question. And like I said, Mark and I have actually done a few N of 1 studies on all types of testing on patients and trying to make sense of what are you looking at with each type of testing, and what type of hormone.
Yeah. Well, so that's such a perfect transition into our next topic of progesterone. So to make that transition, what are your thoughts on saliva testing?
So I think saliva testing is, for me, I feel like it really helps quantify estrogen load because you have that 17 beta HSD that you can turn estradiol into estrone. Estrone agonizes the alpha receptor of the breast differently, which causes growth, right? And so it's going to cause growth more than estradiol when you're worried about breast cancer risk. And so the type of estrogen and the ratios to me matter in the high risk patient and also in the non high risk patient. So for saliva, I feel like it does a good job with that aromatase and with that 17 beta HSD. Quantifying topical hormones. I don't feel you can measure topical hormones in serum. Urine, I don't know if that's the best for topical either. That's the vacuum, right? And yes, you get some crazy results on saliva for some things. I've been using saliva for 20 plus years. I've never really gotten super crazy results. I don't get super high estrogen levels with people on patches. I think I get what's appropriate. And actually ZRT just did their assay. They changed it to an LCMS steroid assay. So it's much more accurate. So they have the steroid 7 now. So it's a lot more accurate as far as hormones. And so I find it useful. Some people think it's easier to pee on a filter paper than to spit. There's a lot of people that don't like to do it. So
They just don't have enough. Yeah. They don't have enough saliva.
Dry mouth, yes. And so that's fine. Again, I'll work with my patient. I probably do less of it now, but I still think it's very useful. I think with specifically the hormone progesterone, any way you test it, you're going to get very erratic levels, whether it's serum, saliva, or urine. Because if you're testing in the urine, 90% of what you take orally is excreted in the urine. And topically, is it really getting into the urine? Because there's some studies that say that it's disseminated in the lymphatics after it goes through the tissues. It's not going to get back into the venous circulation and then go out to the kidneys. So how do we know where is it going after? We don't really know.
Right.
Well,
yeah, and that's been my challenge. So let's talk about progesterone, because progesterone, from my perspective in the bone health world, we know that progesterone has an impact on osteoblasts. We know that it helps with osteoblast differentiation. It is part of their studies that looking at women who have dysfunctional cycles, who are premenopausal, if they don't meet, I think the threshold is 5 quote unquote normal cycles per year, they start losing bone. So we know that push full of progesterone, estrogen is important. Progesterone is important for bones, but never studied independently, because who uses it independently except for maybe me and you? So, but the challenge we always get is people say, well, I don't either tolerate oral, my doctor won't prescribe it for me. Why not topical? So walk me through your topical oral paradigm.
So, obviously the oral is FDA approved, micronized progesterone. It only comes in 2 strengths and it's immediate release. And it used to be in peanut oil. I don't know what it's in now, but some people don't tolerate that. You're right.
I think it still is.
Effect. Yes.
Yeah.
So first of all, think about watering your plant, all the water for the week, one day. It's only going to absorb so much and the rest is going to spill over. Some people do fine on it. And, that would be our first choice. And then you could go to a compounded. Now, I have no concerns about compounding pharmacies. I work with pharmacies that are PCAB certified, which means they've gone through rigorous testing to make sure their SOPs are valid, and they validate make sure that, yes, there is 110 milligrams in this. So they clinically send out. So, I don't have concerns on that. And there have been a few published studies on compounding that there's no concern,
Yeah.
not about hormone HRT, but on other medications. Yeah. And so, you can do a variety of oral doses with a compounding pharmacy. Topical, the issue with topical is when we start adding estrogen into the mix, we don't have a study saying that it protects the endometrium from the stimulation of the estrogen. There's one small study by Helene Leonetti that she actually did a very well-constructed study that she gave, I think, oral, or maybe it was topical, and then did a washout and did endometrial biopsies. And there was no concerns with endometrial hyperplasia with the topical progesterone, but it was a small number of patients. It's not that it doesn't, and there's also other studies with topical progesterone and histology as far as the endometrium, but nothing large term enough to say when you give estrogen, it protects the uterus. So you can do that, but if people have breakthrough bleeding or if they have an endometrial thickness, then you probably have to make sure they're on some sort of oral. I also do progesterone in a troche form. Now, if you don't have a uterus and we're not worried about protecting the uterus, I'm still worried about protecting the breast. That is always not someone's opinion, but I don't give unopposed estrogen. So then you have the freedom to give it however you want. And so you can see an elevation of blood spot levels with topical dosing. It's getting in there. So, you will see those levels go up, but again, no one's going to do this study unless it's a drug company wanting to get a product to market. Right. So that's the problem, is that clinically I haven't had a problem. I have some people who are on topical who insist they want to be on topical. They don't bleed. They take estrogen. They're fine. If they bleed, they know we're going to have to give them some sort of oral. I find topical to be extremely useful for younger patients, especially in perimenopause, because the pharmacokinetics are that it just stays around longer. And so when you've got oral progesterone that's in and out so quickly, this is going to stay around a little bit longer, kind of a depot effect. You're just going to get better symptom resolution for bleeding, for all kinds of symptoms. Now, when you take the oral, you're going to get that allopregnenolone that's going to help more with neurosymptoms of anxiety and sleep. It's not that the topical won't help, but you're not going to get it as an immediate effect as you will when you give oral. So I do use both in the correct patient. And like I said, I even use troches as well.
Yeah. Yeah, we've gotten a little bit more broad in our recommendations. Early on, I was trained no topical. Topical, you can't defend yourself. You don't know what's happening. And you don't see it in blood. I mean, you don't see it in serum. You can see it in finger stick spot test, but you don't see it in serum blood. And so we are opening that up to, again, certain circumstances, particularly women that have had a hysterectomy. So now we have that opportunity. It is sometimes convenient, which sounds weird, but this is two surgeons talking about missing body parts. So I think we can do that. All right. I know we've been going a really long time. I wonder if maybe we save testosterone for its own discussion. Yeah. Androgens is a big talk. It would be a disservice to do it in 5 minutes or less. And we've been recording for longer than we should. I try to keep these digestible.
Yeah. People lose interest. So yeah.
Yeah. So, all right. Well, let's end there. Dr. Scott, thank you so much for your time. And we will put all your links to the Hormone Guru and all of your other social media platforms in the in the comments area for the YouTube channel. And then on the podcast, you can go to the landing page and you'll find it all there.
Awesome.
Any last thoughts for the audience?
I mean, again, just thanks for partnering and getting the information out there. I know it takes a ton of work to do a podcast. And so, I mean, it's really important. And now with social media and YouTube and the internet, people can vet these providers and look for the evidence and advocate for themselves to getting the care they need.
Yeah. And I agree with all of that. I'm one of the things I usually end podcasts with when I'm a guest is to say that it's so important to advocate for yourself. And I think it's the most important for women, especially in this post-menopause timeframe, because the care right now is just not designed to take good care of you, just period. You really have to find the people, and it's weird now on social media because you almost have to find the influencer that makes sense to you. It's like you're relying on the Instagram AI algorithm to steer you in the right direction. It's very strange. But find that person, vet them, look at their credentials. Does this person seem like they know what they're talking about? Are they seeing patients? Are they prescribing? And are they having good results? Learn as much as you can and then follow those people and block the rest. All right, Tara, thank you so much for your time. And we will have to do a part 2 with androgens.
Absolutely.
I hope you enjoyed that video with Dr. Tara Scott. I really enjoy the way that she went through estrogen, the way that she sees estrogen risk in her practice. And that conversation around estrogen metabolism and Dutch testing, urine testing, saliva testing was all fantastic. So I hope you found that enjoyable. If you still have questions about hormones, I want you to consider joining me in my free masterclass. This is a masterclass specifically on hormones. And we want to walk through some of the risks, the benefits, and the different ways of treatment. So you can join this masterclass to help you get on your path to your own hormone success story. So look for the link in the description on YouTube. And if you are looking for our webpage, go to pemabioidentical.com and you can find a link for the masterclass there.